Hello, friends. Welcome to Heart Talk, the number one podcast in your hearts and minds. We're here at the Heart Hospital today, broadcasting live from our studio in the Heart Hospital Plano. We have shown you how the hospital got started and what it built to in terms of quality patient care and quality of the infrastructure and employees and people over the past 20 years. We had the segment with Mark Ballantyne, the president of the hospital, who has led us through this evolution. Today, we're fortunate to have with us Dr. Mike DiMaio, who is chief of staff of the Heart Hospitals, as well as the director of research and education. And in this light, we have a story to tell today that he will lead us through about how research was the platform that we used to build the quality of the Heart Hospital.
You're listening to Heart Talk with your host, Dr. David L. Brown. Dr. Brown is an interventional cardiologist, innovator, and co-founder of the Baylor Scott White, the Heart Hospitals in Plano, Texas. He now serves as president emeritus of the Heart Hospital's medical staff. And now, here's your host, Dr. David Brown.
Dr. DiMaio, welcome. We're glad to have you on Heart Talk. We appreciate you taking the time to come join us.
I am happy and honored to be here, David. Thank you.
Looking at your background, we see music, a little bit of Cuban, Tampa, cigars, all sorts of interesting things. Can you give us a little insight into how all that came to pass and what your background is?
Sure. Yeah, you're being kind. I have a very checkered past, you might add, but
I try to stay away from that.
Well, there, you're being kind again. Thank you. Appreciate that. So you're referring to my background growing up in Tampa, Florida.
Yes.
It's interesting. We're all immigrants here. Most of us are immigrants to this country. The main reason I am here is because of the grandparents, and they all came to this country for one main reason.
Okay, music.
Wrong. Cigars. They're all here for cigars.
Here we go. So I'll ask you right there, Macanudo or Dunhill?
Ooh, neither. I'll go with Arturo Fuente because the factory was about 3 blocks from my house where I grew up, where the Arturo Fuente cigars were and are still being made.
And so you were 21 before you had your first cigar?
Absolutely. Absolutely.
Okay.
So the short version is that the cigar industry moved from Cuba to Key West to Tampa because the best tobacco was and is still grown in Cuba. And they had to make the cigars, and initially it was in Key West, but due to too many hurricanes, they moved it further north to the west coast of Florida, to Tampa. And a guy named Ybor, spelled Y-B-O-R, created an entire city.
Like Ybor City.
Ybor City. And so he needed workers to make the cigars, and so he imported Cuban, Italian, and Spanish workers to make the cigars in Tampa, Florida, in the suburb or the section called Ybor City.
So, DiMaio doesn't sound exactly Cuban.
Good job.
Heritage is?
So the DiMaio side is an Italian name, and truth be known, my Italian side, my father's side, he was a physician, a doctor, and he was brought in to be the doctor for the cigar workers. On the Cuban side, my mother's side, they were workers that were brought in to roll the cigars. And my grandfather was the one who rolled the cigars. Literally, you see the pictures of people on the tables rolling cigars. And that's what he did. My grandmother, however, was a stripper.
Okay, that gets us to a good jumping off point of food. With that background, Italian or Cuban?
So, Cuban.
Cuban. Okay.
You passed on my stripper comment, though. You don't know
I did pass on that comment.
So my grandmother would take the leaves.
We've got an audience age 3 to 93 here.
Well,
go ahead.
We can be careful. So actually, you take the big tobacco leaves, and you need to strip the main vein out of the leaves in order to roll a cigar. So she was a stripper that stripped out the veins of the leaves before they rolled the cigars.
So you gave me the perfect lead-in, and I dodged the whole bullet.
We can cut that in, though.
Okay, and there's a little bit of music in your background,
yes,
right?
Sir.
So how did we get from there to music?
So after graduating from University of Florida, I was not exactly sure what I was going to do or go or be, and so I had an opportunity via my college roommate who was very big with Bill Graham and the big rock promoter. And so he asked if I wanted to help out being a roadie, and I said yes. And so I was a roadie for several bands, including Fleetwood Mac for the Rumors Tour, which is a very famous band in a very famous tour. Still the most successful selling album of all time.
So, in a wide open question, if Fleetwood Mac isn't your favorite band, who can beat them with that kind of experience for you?
Dire Straits is probably my favorite band for the quality of music for rock and roll.
Okay. And if you get to solo Elton John, Billy Joel?
Tough decision. A great concert is actually both of them. They had a concert called The Piano Man. They used to actually go play together, Elton John and Billy Joel, with two pianos facing each other, and that was probably the ultimate entertainment / piano playing duo you can imagine.
We see this background. We've got the music piece. We've got the job. And we're sitting here today at the Heart Hospital. You're a heart surgeon, chief of staff of Heart Hospitals, director of our research and education. How do we go from music to healthcare?
So that's a longer road. And how long is this podcast? How long do we have?
I think
how many hours?
Two,
minutes?
2 hours and 55 minutes.
All right. Well, we'll
We're
try
under
to cut
3
it
hours.
short. So the shorter version is, as I mentioned, college and then roadie, then did some work for the White House, did a startup company and sold that, then worked for a pacemaker company. And so the constellation of those led me back to my love of science and research with a company. And working with the pacemaker companies, I realized that cardiovascular surgery or heart surgery was very, very cool. So I wanted to be a heart surgeon. So I decided at a little later age than most to go to medical school to go on to become a heart surgeon.
How about this? How about telling the audience how we met and how you came to be here at the Heart Hospital?
I remember very well meeting you. You organized, you and Mike Mack, the Dallas-Leipzig series back and forth. And not being in the organization, being outside the organization, I looked upon you with a good bit of jealousy and respect that you were organizing, which at that time was a premier medical surgical meeting in the world, because you led the way with the transcatheter TAVR devices, and that meeting was the preeminent meeting to be able to recognize what was coming down the pike and on the horizon for that therapy.
Can you take that and lead us a little bit into what made you come over here, how we got you here, and how we're fortunate to get to where we are today?
Well, thank you. That's a very good question. And I'm going to say it again. I looked upon you and Mike Mack and Will Ryan with a good bit of jealousy and respect and envy, because even though I was a neighbor and not in this institution, I was seeing what you were doing and growing here at the Heart Hospital. And I would hear this sucking sound every now and then. And that sucking sound was a sound of patients being taken to your institution, to this institution, now ours or mine, because of what you were building. And so you were combining excellent quality clinical care, taking excellent care of patients, with the ability to have leading, bleeding new devices, and having the clinical trials which were necessary at that time because they were all under research studies. You couldn't get them normally. And so you literally were leading the way, and I wanted to be part of it. And at that time, I wasn't and couldn't be, because you had the space and you were doing what you needed to be doing. So I think patients and other doctors and investigators like me were envious.
Can you take us for a moment from the beginning of research, where it was the Heart Hospital, and then as you have taken over as director of research, where we've gotten today and how we got here?
Sure. And again, I say it again, the foundation you built is extremely strong. So the pillars that you put into the ground of research is what we've been building upon. What we've tried to add since that time is expanding the depth and scope, because I think primarily you mentioned the stent trials and the TAVR trials, which were key and essential. But we wanted a more broad-based set of studies. So right now it's actually more than 100. It's about 120 clinical trials are either ongoing or in process, and about another 20 are going to be started up in the next few months. And so we just continue to organize that. Better is not the right word, just more organized silos. And now we only had one big group which was going on, but then we have now cardiology, electrophysiology, cardiac surgery, vascular surgery, aortic surgery. So all these different pillars or silos of research are being filled by different clinical trials. The other thing we added is that we learned that if we do them efficiently and correctly, we can then segue to and use the resources that we benefit from the industry-sponsored trials, David, to build an academic footprint. And that's the other thing that's been added on, is that we now have an academic footprint with PhD statisticians, multiple clinical research fellows, other staff that has a whole array that really rivals and overwhelms most academic centers, traditional academic centers. So the answer is we built upon the foundation you built with the clinical trials, made it wider and deeper, and then use those resources to build a truly academic unit as well.
In previous episodes, we talked about the fact we didn't start out being an academic center. We weren't really a university setting. We were private practice, trying to take the best parts of clinical practice, research, and even before we got anywhere near postgraduate medical education. But as we did that, can you touch on a couple things that were extremely important to us at the beginning that I think we've had some achievement in, and that is enrollment in trials a little bit and publications that come out of that, essentially from this non-academic, non-university setting as we built this program?
Sure. So I'm going to say it again, quality is the most important matter. Having involved and active principal investigators. So we don't just participate in trials. We make sure we ask that any of our trials that we enter, we expect to be in the top 3 or 5 enrolling centers in the country or the world. Why is that important? Because if you do that, you will be on the podium presenting these trials, and you will be on the publications that are presented discussing these trials. And next point, which is important as well, is that you will be asked to do the next set of trials, which you mentioned are early feasibility studies. That's something we're in the top tier of institutions in the world that have access to early feasibility studies. As you know, and the audience may not know, early feasibility studies are the early phase trials when a new device comes out of the engineering companies that are produced, and the first several or dozen or so devices are put into people. You learn with the engineers being in the operating room or the cath lab and seeing what's going on with that device so they can go back and iterate it or improve it as necessary. The other thing you mentioned with these trials is publications, which is a currency that academic units use. And since 2018, we've produced almost 1,000 publications out of this institution. And again, I kind of toot our horn a little bit, if I might. That's really better and more than most academic institutions. And even though we keep saying that we're not, we kind of are, because you have research, we have education, we have teaching, we're training people. I'm not sure what else is missing in an academic center. And we also have affiliation with medical students as well.
Finishing off that earlier point about enrollment, just reviewing some of the data, it appears that there are 20 trials where the heart hospitals are in top 5 in at least 20 of them, and really top 2 in enrollment in 10 of them.
Mm-hmm.
Top enroller in 5 trials. So I think that goes to exactly the point you're making. There's also an aspect that sort of ties research together with the postgraduate education that we'll talk about at the end and get to about what's occurred in postgraduate medical education here in future episodes of Heart Talk. But I think one of the things that you're incredibly proud of is podium presence of the fellows and residents at national meetings and international meetings. Can you comment on that?
Sure. I actually call it the 3 Ps. It's publications, posters, and presentations. I think those are the 3 Ps that most academic or anybody doing research are involved in. You want to have the publications which you document that are peer-reviewed, that demonstrate that what you have studied, what you have looked at, has been reviewed by other people and has been in publication. Presentations and posters are also currency to be able to get the word out on and let your young people talk about these devices or drugs or studies or research trials that are done here at their heart hospitals, to show them and to show patients as well, actually, that they have availability to the latest, greatest research trials and devices that are available.
We talked about TAVR and the foundation that it built. We knew as that evolved, when we were one of only 3 centers in the country that began the early research on transcatheter aortic valve, that if this worked, it would ultimately move more along the historical direction of stents and eventually open centers in most places that had heart surgery, which it has, and that we always had to be looking forward and moving forward to stay on that leading edge that we talk about. Can you comment on what's transpired for us from the early days of TAVR through mitral valve, tricuspid valve, and where we are today?
Sure. So once again, the foundation was TAVR, which for the audience is the transcatheter aortic valve. The audience may or may not know there's 4 main valves in the heart, so that leaves 3 other valves that are waiting to be treated. And so the pulmonary valve, or be a little bit medical or scientific right now, is not usually as effective, but it is somewhat with people with tetralogy FLO. So the next valve is using that aortic valve in the pulmonary position. However, mitral and tricuspid, the other 2 valves that are remaining, are right now in the frontier of research going on now. So we have a number of trials that are going on, MySend and TriSend and others that are approaching the mitral and tricuspid valve, and we are on the leading edge of all those trials as well. So back where the TAVR valve was just the entire valve, in the mitral and tricuspid space, there are clips or rings or valves, all of which we have access to, that we can approach and treat mitral or tricuspid disease via catheters without the need for open surgery. So to your question, those are the frontiers. They're not conquered. No frontiers conquered, but I mean, the TAVR space is more mature. I'll use the word mature. And the mitral tricuspid space are still in the early stages, maybe the first quarter, to use a football analogy, of the 4 quarters that would be necessary to get to that space.
TAVR was used to treat critical aortic stenosis, blockage of the aortic valves. Tell us about the JenaValve.
Yeah, that's a great question. And so the aortic valve can have 2 problems. It can get stuck up, which is stenosis is blocked up, or it can become loosey-goosey or insufficient. And so as you say, the TAVR valves, almost all the TAVR valves are authorized or permitted for use for stenosis. But this is the first valve, and we have access to it by the research trials, for aortic insufficiency. And we've been on the forefront of that, the JenaValve, which is JENA.
Moving to electrophysiology, there's an interesting, exciting trial not using heat or cold. Can you tell us a little bit about what's happening there?
Sure. I think that's another revolution, which some might argue is probably just as big or broad as the TAVR revolution that you led. And that's called pulse field ablation. And historically, the electrophysiologists, which are the fancy word for the electricians of the heart, that disrupt or repair the electric conductions of the heart. So in the past, they used heat or cold to heat or freeze the different communication in the heart. And right now, this new technology called pulse field ablation uses a different technology, which allows them to disrupt the channels of the heart, which cause atrial fibrillation and other dysrhythmias. And they can do it quickly, effectively, with a proposal of many, many fewer complications. So right now, and we've been one of the first sites using it, they're able to do the same study, a treatment study, in probably half or even less of that time than what they did traditionally. So they'll be able to treat patients quickly, efficiently, and more safely.
We also have some stent trials, right? A GPS trial looking at IFR, trying to pin down what's happening distal to the arteries.
You've done your homework. Yes, we've got from head to toe trials from the carotid artery to the coronary artery down to the legs and feet. But the Divine GPS trial, Dr. Al-Azizi's leading that, has been a revolutionary way to use really, besides just taking a picture of the coronary artery, which is what historically cardiologists have done, using dye and kind of eyeballing it and seeing what's going on. Now we can put a catheter or a wire down the coronary artery and measure using the fractional flow reserve, the ability or how much flow is going across the stenosis or how much flow is not going across the stenosis, to determine what size stent to be used and how to size it so that you have the most effective and appropriate stent to be placed across that stenosis. Other trials are going on in the legs, Disrupt BTK and others that are having different ways to access the arteries in the legs to get blood flow to the legs and feet.
So we talked about Shockwave being purchased recently, the Shockwave therapy that you were just talking about in Disrupt BTK. bioreabsorbable stents in one of the platforms, the Javelin for another lithotripsy trial that the vascular surgeons and cardiovascular physicians are using. Heart failure trials. We have some heart failure trials.
We do. Different devices, big and small. I'll start small. We have one study called LAHF, and that's a methodology of making a small hole between the interatrial, left atrial, right atrial wall, allowing a pop-off of the pressure on the left side of the heart to go to the right side of the heart to help alleviate some of the heart failure. Going to some bigger studies and trials, there's some devices, they're called Impellas. They're temporary mechanical circulatory support devices, and we have access to all of them. The biggest ones now we're using for temporary support for cardiology processes such as coronary stenting, and we also have trials going on now using temporary mechanical support for patients undergoing heart surgery. So there's temporary support and more permanent support, and all of those devices are available here at the heart hospitals to provide either temporary or hopefully more permanent relief of heart failure.
So I mean, we've run through heart failure, electrophysiology, interventional with stents, the valve stuff with surgeons and cardiologists, and although we've touched on vascular surgeons, maybe finish the trial thought with something like a RISE-2, one of the very interesting pieces or graphs. Can you talk about that for a second?
I can. And so historically, either cardiac surgeons or aortic or vascular surgeons would replace the diseased aorta, whether it's dissected or it's aneurysmal, meaning that it's the walls have torn apart, or aneurysmal means that they're too big and they disrupt or fall apart. And that's historically the way it was done. Then there was a revolution with something called TEVAR, T-E-V-A-R, which is placing a big stent in different parts of the aorta to help decrease the pressure. A RISE is actually a study using a stent in the ascending aorta, the first part of the aorta that comes out of the aortic valve. And these are for people that are too old or too sick that cannot tolerate open surgery. So by placing this stent here in the ascending aorta, you can relieve the problem that's going on there, whether it's a dissection or aneurysm, and use a stent to relieve that problem.
In that respect, just looking at the research program, where it's been, where we've gotten to, what kind of goals can you have for the research program at the heart hospitals today?
Good question. And so the answers are a couple of goals. We have increased the education of research fellows that we participated in this coming year. We'll have 4 research fellows that are some from the United States and some from other countries that'll be here doing research. We'll expand the academic unit to have even more publications than we have now. And the next big frontier is getting externally funded trials from the NIH and PCORI and other national agencies that are historically or classically been the purview of more traditional academic units. So again, the foundation that you built with the clinical trials and the patients that we have with the academic unit will now be married or joined with the traditional competitive grants that are achievable by national organizations.
Fundamentally, without you, we wouldn't have anything near the educational program we have in postgraduate medical education, right? Mm-hmm. How many fellowships and residencies do we have?
32
now?
People, 32 warm bodies in different stages of postgraduate education.
How many subspecialties is that?
We have CT surgery, cardiology, the subspecialties of electrophysiology, interventional cardiology, advanced imaging, interventional cardiology, all those subspecialties. Structural heart, yes. Mm-hmm. And don't forget, we also have, we keep talking about postgraduate, we have the CVI school too. So we realized that we needed the echocardiographers and
how many
the
schools do you have?
We have echocardiography, perfusionist, and cath lab tech, 3. And we're going to have a 4th one with the EP tech in the next year. And don't forget in research, now we've also, and we're not done with research, we have the Echo Core Lab, because Paul Grayburn is someone who you know, you may want to comment on that, who is a world expert on doing echocardiography, and when he goes into a room, people listen. And he wanted to kind of segue into a different phase of his life. And so I told him, look, I'll do the dirty work, just like I did for you. I said, I'll do the stuff you don't want to do, and I want you to do the stuff that you want to do. And so the Echo Core Labs are reading echoes for all these studies that we've talked about before and adjudicating them. And so now we are a international core lab with facilities in Europe and the US.
I'm reluctant to say the word, but AI.
So AI is overused and overworked, but it is now it's a clear and present situation. As you know, we've had
some people call it the clear and present danger.
Clear and present danger. I think it's both. Yeah, it's both. But you know, AI we've been used for a long time. Our smartphone uses AI. When you go on your Google Maps and you figure out how to drive somewhere, that's really a form of AI. Figuring out, using a bunch of people that had the previous route, integrating that into the current traffic conditions. That's AI as well.
Well, HeartFlow started using it before most institutions with,
yes,
coronary imaging they had. You founded a company, Spectral MD, maybe 15 years ago or so. You started using feedback and essentially early artificial intelligence before country was cool, right?
Yeah, that's right.
I mean,
we did.
Even before it was called AI, right?
That's right. Right.
How far back, if you think about it, were you really using AI before it was even called AI? How far back?
So it would be a good 8 to 10 years from today.
Yeah.
And we started the company, as you know, because you were very instrumental in it as well. And just having a device that can look at wounds and image a wound and predict that particular wound, whether it's a burn wound or something else, would or would not heal in a certain time point. So the way you do that is you image the wound on the first day that you see it, and then 7, 14, 21 days later, you take those images, go back to the original one, and look at it pixel by pixel and figure out by an algorithm, which is called machine learning or deep learning and all these other algorithms, on what would have predicted that particular pixel or that wound would have healed. And that's AI. And when you take that wound 21 days later and you saw what healed or didn't heal, there's fancy ways to look at that and see what they call features. It's called feature extraction. What features in that wound or in that pixel predict that it's going to heal? It's like HeartFlow or your Google. Google is predicting, the Google Maps is predicting that if you drive this route, based on all the information we have, that there's a traffic accident, a policeman, it's predicting that you can get to that spot in 20 minutes. It may or may not be right or wrong, and it modifies it as you drive. You may not realize that Google Maps does that. And when you're 10 minutes into it, it's constantly upgrading it. And now there's an accident, it says, oh, stop. You better take a right-hand turn here and get around it. So all of that's AI.
All right. I think one of the things that we've been fortunate at the hospital, there really have been at least 3 big companies. I mean, Edwards, Medtronic, St. Jude Abbott combination, and now you mentioned Univalve earlier as the first piece of this to try to treat the insufficiency or the leak in the valve. And there was a time where in Europe there were 20 different valves wandering around in the EU and trying to get established. It's been an incredible sort of regulatory environment to get all that done in. And I would say certainly those 3 companies, helped lead this institution into the 21st century with the whole TAVR development.
Well, the future, you mentioned these different valves, and you mentioned AI. We literally had a meeting yesterday with certain regulatory people and other investors and other people that are really important in the space to figure out a way to use AI in the current medical records to be able to do these studies that you did with the partner trials, and to do some of them or add to it in a simpler way. Instead of all the manpower that's used for what's called CRFs or these research forms, can we just extract that information right from the record, right from the medical record, and not have someone sitting on a desk copying and pasting what's in the medical record to a computer?
Well, I mean, one of the things you remember, I think you were here already. We had to both almost hire a couple of people and assign a couple of people to go back and look for obituaries going back 1 year, 5 years. Another thing, we had to go track down are people dead or alive, which is not that easy. And you were telling me the other day about the smartphone application. Can you tell me?
So we, Google Verily came to us, the heart hospital, and said, we want to do a study where we're just going to use a smartphone and the patient is going to enter information on the smartphone and follow what's going on. In other words, we enrolled 20 patients out of our heart failure clinic in this case, and they're going to report their symptoms in their phone, whether they're having shortness of breath or weight gain or whatever. And we can follow them on the smartphone and see how they're doing. But in addition to that, we can follow, because there's so many searches being done, whether you've had a car accident or you picked up a prescription or you've been searching on the internet, we know that you're alive, or we know that you got into the hospital. So we don't need someone to literally track you down. It's literally the algorithms that you give permission for, of course, are following you and seeing that you fill a prescription for metoprolol or a diuretic. So the smartphone and the ability to search the internet allows us to follow patients and see whether they're well or not.
George Orwell in 1984 wasn't really a joke.
No.
We know everything about you now.
We do. And you may not know this, but it took us a long time to get the consent form for that, because people are allowing us to follow every aspect of their life via the internet.
Let me read you something.
Yeah.
It's interesting about really the heart hospital development, the development of the research program, where it's gone, and something that we're all incredibly proud of, right? CRF, that everybody in cardiovascular medicine knows, Cardiovascular Research Foundation, that you can wax eloquently about, but they launched the Scientific Excellence Top 10, looking fundamentally at academic contributions to this kind of research, right? And their annual rankings looking at essentially global academic institutions. And in 2023, the Heart Hospital ranked number 4, behind Cedars-Sinai, Mount Sinai, and Mayo, and even ahead of, I'm going to say, New York Columbia Presbyterian, with the base of CRF. But you can name every other academic institution in the country, and there are only 3 that ranked above that in what we've done here.
Well, something to be proud of for what you've done and what we built upon that. But Mount Sinai and Cedars-Sinai are outstanding institutions, very proud of them. And just to be in the same sentence as them and be ranking in the top 4 with them, the CRF, the Cardiovascular Research Foundation, that meeting that runs all that, is the epitome of clinical research and innovation. There are a lot of big meetings in the world, but that meeting really captures the whole essence of innovation. And the fact that we're in that same census is pretty impressive. I keep debating and arguing with you that we're an academic institution, because I'm not sure exactly how you define it. But if you have clinical care, if you have research, if you have education, if you have students running around, if you're affiliated with a medical school, I think we're pretty much as academic as you can get. We may not have all the accoutrements of deans and presidents and sub-deans and provosts and everything else, but if the purpose is to be able to take care of patients, do research, train the next generation of students or doctors, we've checked those boxes.
So I think we've stopped fighting about that, actually. I agree with you. It is an academic institution in all those things you said, and maybe it doesn't have the chancellor and other things. And maybe the thing that I used to say early on when I said we weren't an academic center or a university setting, I think that's probably changed, right? And I think all the things that you just iterated, it really is an academic institution in all those ways. Maybe it doesn't have university after its name, and maybe we're not sitting on the grounds of a university, and so we might quibble over. It's become an academic institution out of everything that we built.
Yes.
Fundamentally from what we talked about in previous shows of private practice.
That's right. That's right. Well, private practice is taking care of patients. So whether you're taking care of patients in a traditional academic institution or in private practice, you're taking care of patients. And you and we take care of patients with the heart team approach that you help innovate in a great way. All the quality metrics that you can use to measure cardiology, vascular surgery, and cardiac surgery, we're at the top of the heap of all that. So must be doing it pretty well. So this foundation we talk about, we keep mentioning to it, but if we're going to introduce the next show, all this foundation leads to what do you do with the next, what do you do with all this? Great care of patients, top-notch quality, 3-star, 5-star, et cetera, researching, answering questions. The answer is to train the next generation.
The platform including the research now, is incredibly important to this training program and to the 32 residents and fellows you talked about in nine, essentially, I think 9 different subspecialties, right? So we've gotten there, and now we're on the edge of being a key component to training the next generation, right?
Amen.
And you know, I'm old enough now that we're a couple of generations into training, right?
Yes.
Whatever, Gen X, Y, Z, A, maybe there's a B coming. So there's a lot to train.
Well, you were the inaugural program director for cardiology. You'll be proud to know that all the cardiology and all the cardiac surgery fellows that we've trained here have all passed their board examination, which is a test of how well you trained them, both their oral and written exams on their first try.
So in all our training programs, most of them have got to go take some kind of exam, credentialing, something. So in all our programs, what is the pass rate?
100%.
In all the programs?
In all the programs.
Have we ever had somebody fail in any program?
No. We've even had someone pass the echo sub-exam in cardiology, which is usually done in the 3rd year. We just had 2 of the fellows pass it in their 1st year of fellowship in cardiology. And this year, the cardiothoracic fellows take an examination during their training to see how they're doing. They all scored at or above the 97th percentile. So again, the foundation of this clinical program, and they're literally watching how our doctors are taking care of patients, and they're learning how to do it the right way, to the point they can answer the questions on the exam and get the answers right.
Thank you for joining us, Mike. Thank you for being here. We're really appreciative of your time. Thanks.
Love to be here. Thank you,
Great
David. Appreciate it.
Thanks, Mike.
Views and opinions expressed by Dr. David Brown are his own and do not necessarily reflect the views of the Baylor Scott White, the Heart Hospital, or any of its officials. The views expressed by guests are their own, and their appearance on the program does not imply an endorsement of any of them or any entity they represent. The information provided herein is considered educational and should not be used during any medical emergency or for the diagnosis or treatment of any medical condition. A licensed medical professional should be consulted for diagnosis and treatment of any and all medical conditions. Call 911 for all medical emergencies.